So just to get us back on the same, something that we all know is to think about prostate cancer and this, lengthy disease process that we all have, sometimes witness in our patients. We have clinically localized disease that we've talked about a while, but some of those patients will die of other causes in this elderly population long before something happens. These can have biochemical recurrence. We don't detect their disease with current imaging technologies, but a lot of these patients can also die of something else before their prostate cancer gets them. And it is really sort of in some of these later stages where death from other causes becomes a much less important issue, and death from prostate cancer becomes a overriding burden. And I think that we have to recognize that the timeline for castration-sensitive disease, there's a 10 to 15-year life expectancy for biochemical recurrence and approximately 5 years for those who present with overt metastases. And in our patients who often get this disease with other comorbidities, lots of things can happen in the meantime. And I think we're going to have to think about that because there are other things besides prostate cancer that impacts these patients. So we've already heard and we know that the androgen receptor and testosterone are the most important targets for this disease. So what does testosterone do in the adult male? Well, it's important for aggression and libido. That has effects in the brain itself. It's important for maintaining the size of the prostate, penis and testes, and required for sperm development and maturation. It's also, though, important for muscle mass, bone mass, and metabolic effects. And then muscle mass is something that we've all known from people like Lance Armstrong who've used it for these purposes. So this is the endocrine axis. We know that the LH-RH releasing hormones are secreted from the hypothalamus. They stimulate the pituitary to secrete LH and FSH, which then stimulate the adrenal cortex as well as the testes to produce the androgens that drive this particular cancer. And we can intervene at multiple locations. We can remove the testicles. We can give a GnRH agonist, which then essentially turns off this feedback loop. We can give anti-androgens, and we can block tumor and adrenal androgen synthesis with some of the newer drugs that we have available. Now, what's the morbidity of doing this? Well, it's the opposite of giving testosterone. You get hot flashes. So do women who go through menopause. Men just complain more. Loss of libido and impotence. There's gynecomastia, especially with the anti-androgens. Weight gain and loss of muscle mass. You lose muscle mass. You eat the same amount. You sit around more. You gain weight. There's exacerbation of hypertension and diabetes. There's fatigue. There's osteoporosis and fractures, and I think an understudied area is that there's some real emotional effects of androgen ablation that are probably completely under-recognized by the typical male physician who treats these patients. So here are these toxicities listed again, and listed perhaps slightly differently, but we've contrasted and compared this to a condition that my geriatric colleagues describe as frailty. So frailty in the geriatric population is defined as exhaustion and fatigue, weakness, weight loss, decreased activity, slowed gait, osteoporosis, and falls. And so we began to question whether does androgen ablation actually cause frailty in our older patients. And here would be sort of a conceptual process by which this could occur. You lower the testosterone in an aging patient, you get lower muscle mass or sarcopenia, you get some lean muscle loss, you get lowered muscle power, you get weakness and fatigue, you get impaired mobility, you get low activity. And this is the conceptual framework. We published this a number of years ago. Does this actually happen? And the answer is yes. These are some smaller studies that we published a couple of years ago. In a cohort study, we had 50 men older than 70 on androgen deprivation, no metastases, and 24% had deficits in the activities of daily living and 42% in the instrumental activities of daily living. We did a physical performance battery, and half of them had deficits. Falls occurred in 22% of these patients. And then in a case control study, 63 men with biochemical recurrence who were on ADT were compared with 71 survivors without such therapy, and the BMI was increased in those on ADT, and the falls were markedly increased in those men on ADT as well. Does this matter? Well, we know that osteoporosis is also caused by ADT, and we get increased markers of bone turnover very quickly and decreased bone mineral density that's detectable within 3 months of androgen ablation. So if a man is weak and his hip is frail, and he trips over the curb in the Chicago winter because it's icy, bad things happen. So these are bad things, and here's data from Matt Smith looking at the incidence of unadjusted fracture-free survival. The upper curves are essentially the control, or if you've only received 1 to 4 doses of an LHRH agonist. The lower doses are for patients who have gotten more prolonged androgen ablation. So given these concerns, when should we start androgen deprivation in men with biochemical recurrence? Early versus delayed androgen deprivation was a subject of multiple studies, mainly in the VA. Over 2,000 patients were looked at. All these studies were done prior to routine PSA testing, and this generally favored, quote, early, but if you looked at those data, only at 10 years after initial therapy. We also know a little bit about the natural history of the post-surgical biochemical recurrence, and I show here some of the data from Anthony D'Amico, segregated by patients who have biochemical recurrence following prostatectomy based on whether their PSA doubling time is greater or less than 3 months. And I think we should point out the x-axis down here is in years. That right-hand point is 10 years, and here we have the approximately 10% of patients who have died from biochemical recurrence of their prostate cancer at 10 years if they had a doubling time of greater than 3 months. So how do we decide? We did a small study where we looked at the factors that drove physicians to start androgen deprivation. Here is the list of different factors that we've looked at, but what's probably most interesting is that the patient's anxiety about his PSA was one of the strongest predictors of starting androgen deprivation. And I would argue that a patient's anxiety about his disease is not necessarily a good metric for medical decision making if that anxiety is not necessarily linked with appropriate risk benefit of the associated therapy. So what about the obvious also? Lupron, a 3-month depot, the annual cost is somewhere around $10,000 to the payers. I looked this up on the web. It's about $3,000 for a simple orchiectomy. And keeping your useless testicles, I'm not sure what that's worth. But I think we need to think about it. So, what about the intermittent? People say, of course, I can't do intermittent therapy when I do the orchiectomy. Well, here's some of the data for metastatic disease. Intermittent therapy is statistically not non-inferior to continuous. That statistical tongue twister basically says not a lot of advantage. And there's not a lot of difference in terms of outcome for patients with biochemical disease. There may be better quality of life, but most of that is in that first off cycle when there's less hot flashes and perhaps some increased desire for sexual activity, not a lot of other improvements in quality of life. So then what about if you give androgen, the LHRH agonist for a long period of time? What happens? This is a small study I picked out. So 15 patients who had been on LHRH agonists for 73 months. The LHRH agonist was stopped. Only 1 patient with a 31-month follow-up had recovery of their testosterone. So if you give LHRH agonists for 4 or 5 years, and especially in elderly patients, many of those patients will not recover their testosterone even if you stop the shots. And so we keep giving those shots every 3 to 4 months, supporting our pharmacies, but not much else. So being old, sarcopenic, and osteoporotic is bad for patients. If we, the docs, cause 2 of 3, that's probably bad as well. We can't take the blame for causing oldness, but the other 2 we can take blame for. Elderly patients with biochemical recurrence of prostate cancer and medical comorbidities may not live long enough to experience prostate cancer morbidity and mortality. And intermittent LHRH therapy does not equal intermittent testosterone suppression. And in an era of cost containing, it may be much more favorable to support our surgical colleagues than those in the pharmaceutical industry when we think about androgen ablation. So I will stop there and happy to answer any questions.
So that was great. Now, so I just heard, for Dr. Sweeney is that we want to do a lot early, and then you say, why do everything late? But is there what is the type of patient though, because it sounds like there has to be in your head a type of patient that you say, look, I'm going to delay doing most anything as long as possible to reduce the side effects of it, and then when I have to, start it, versus I saw, the younger patient and everything, that I'm going to be very aggressive up front because I know there's a long time here. How do you kind of distinguish those two?
Some things are obvious if you spend 10 seconds thinking about them, right? The patient with on dialysis, on oxygen, who wheels into the your exam room with a PSA of 0.08 after their surgery 10 years ago. Those are obvious, right? Those are the patients who you really should not treat at all, because the only thing you're going to do to that patient is make his life more difficult. I think that the other end of the spectrum, is also easy. The young 55-year-old gentleman who had, his prostatectomy 6 months ago, and his PSA is now, 5, and he already has an enlarged lymph node in the retroperitoneum. It's also obvious. It's the in-between where I think that there's a little bit more of a discussion. And we do have lots of discussions with our elderly patients, and especially some of our elderly patients. We sort of say, okay, here's some of your other comorbidities. Let's think about what your survival is going to be with those. Let's think about what these toxicities are going to be. And let's sort of make a decision at what point we might want to start the androgen ablation. And sometimes that's a longer conversation, but having that conversation over a period of 2 or 3 visits is often the easiest thing to do. So I rarely, if ever, start an elderly patient on androgen ablation within the first 2 visits of their biochemical recurrence.
So what do you do about the 79-year-old farmer who's still working his fields?
Just, then we begin to look at things like PSA doubling time, right? If his PSA doubling time is, 18 months, we wait. If it's 3 months, I can say, well, we don't start today, but you may want to think about we're going to likely start soon.